Hey, I'm Jack Cush. I'm here at RWCS in Maui, 2019. Great meeting. I want to tell you about my debate with Dr. Roy Fleischman. Roy and I have been calling it the Great Debate, trying to drum up some interest. It wasn't actually billed as such. We had a good crowd. The topic of the debate was, should pre-RA, should preclinical rheumatoid arthritis patients, should they be treated? Meaning that if you identify them, should you put them on a DMARD? And as you know, this is a growing area of research interest that we know for many years that long before the diagnosis of RA is achieved, that patients can have autoantibodies going back 10 years earlier that would antecede the onset of disease. And this has led to a whole new area of investigation, preclinical RA. You start out with someone who's at risk, genetically at risk, having a shared epitope or being homozygous for the shared epitope, that along the way they develop autoimmunity, usually as a result of environmental triggers like smoking, obesity, etc. And then the autoimmunity they get is manifest as autoantibodies, CCP, rheumatoid factor, CAR-P antibodies. These are all present as far as 10, 15 years before the onset of disease. The interesting thing is that as they get closer to their diagnosis date or the onset of synovitis, bilateral symmetric synovitis, they get more and more of these autoantibodies. So you know that early RA patients who are diagnosed, often only are going to be rheumatoid factor positive in 40 to 60% of the time, but that is over time, that will go up even further. So it is a continuum of autoantibody expansion, epitope spreading, that will lead to more autoantibodies. And so the idea here is that, is it a defined point that you need to be worried about, or do you need to be worried about them beforehand? I made the case in favor of, in fact, I was forced to take this position, that you should treat patients at the preclinical RA stage. So I wanted to start out with what's the definition of preclinical RA. And there's two that were reviewed in this session. One is a first-degree relative of someone who has a diagnosis of rheumatoid arthritis who is CCP positive and has arthralgias. That would be one definition. Second one that Roy also reminded the audience was someone who has one of these rheumatoid factor, rheumatoid-like autoantibodies along with symptoms. Now again, either definition cannot actually achieve old 87 criteria for rheumatoid arthritis or the newer 2010 ACR/EULAR criteria for the diagnosis of rheumatoid arthritis. So the idea is that again, they're sort of set up. Well, the data I showed that if you're just seropositive, the risk of developing future inflammatory arthritis and rheumatoid arthritis ranges from roughly 20 to as high as 70%. So there is some risk there. The numbers go up when you start adding in other risk factors, being double positive for CCP and rheumatoid factor, or being found in a secondary clinic like a rheumatologist clinic as opposed to a general health fair screen. And you know, obviously there are other things, including the environmental and lifestyle triggers that can further add to that risk. Being first-degree relative adds to that risk. But just based on the autoantibodies alone, it ranges, and probably it's around maybe a 30% might be the average risk. And I think that's something very important and worth knowing. But is that enough to make you treat? And the whole issue here is it's an opportunity for prevention. And that was my tact. Get people to think if we treat during this window, this true window of opportunity, that in fact, that you may be able to affect the outcomes. The evidence of that, however, isn't so good because the trials aren't so good. There's a number of trials done in steroids, in dexamethasone, high-dose steroids, where it didn't work. You know, short-term improvement, but no one got any long-term protection or no deterrent from getting rheumatoid arthritis. There's the PROMPT trial where they used methotrexate in undifferentiated arthritis, which is not the same. Those patients are a little further along the continuum. Again, the continuum starts with genetics over here, then environmental triggers and autoimmunity, then early undifferentiated disease, and over here you get rheumatoid arthritis. So undifferentiated patients not meeting rheumatoid arthritis criteria, they were given methotrexate, and early results looked good, later results, long-term results didn't look good at all. But there were people in that subgroup who did benefit from getting methotrexate even at the pre-diagnostic stage. In the end, Roy showed data that wasn't too impressive. The steroid data, the PROMPT data, the Prairie study, a few others. Again, the studies weren't very good, but the studies are limited by short duration of exposure. Prairie study was a study of rituximab being given one infusion, 1,000 milligrams, and following people out for 30 months. It actually did forestall the development of rheumatoid arthritis. It took 16.5 months versus 11.5 in those who got placebo. There was fewer cases of rheumatoid arthritis, 34 versus 40. So the numbers, the effects were not great here, but they got suboptimal therapy. The same was seen with 6 months of therapy with abatacept, where again, the long-term benefits were little, but they only got 6 months of abatacept. So there are more studies that are in progress right now, and maybe we'll know more. In the end, we had a vote, Roy taking the position, showing the negative view by the crappy data that we both were using, seemed to sway the audience into thinking this is not something you should be doing. I tried to make the case that I was right, and people just had a hard time understanding my masterful presentation. But in the end, I think it was a good discussion. We had a lot of questions from the audience. I would tell you that the takeaway from this should be the following. The people you need to worry about who are not yet diagnosed with rheumatoid arthritis are the following. Those who are double positive for RF and CCP, a high percentage of those people are going to get rheumatoid arthritis. And I'm saying greater than 250 CCP, many hundreds or thousands as far as international units of rheumatoid factor. People who have seropositivity and who are first-degree relatives, that's also a group that you need to worry about. And of course, people who have one joint becomes two, becomes three, becomes four, you're already on the way to making a diagnosis of rheumatoid arthritis, and how you intercede is going to be up to you. That's it from RWCS. Tune in for more interesting videos from this great conference.